Good morning to everyone.
It's my privilege and honor to introduce Dr. Raj K. Narayan, a distinguished neurosurgeon leader, researcher, mentor, and CMC's friend, as the Dr. Jacob Chandy Orator for 2026. Dr. Raj Narayan completed his MBBS from CMC Vellore in 1975 as a member of the batch of 1969. He participated in a research project on concanavalin in our department's neurochemistry laboratory during his undergraduate training, laying the foundation for his interest in neurosurgery and research. So with $8 and a suitcase, he then landed in the Medical College of Virginia, Neurosurgery department, and he was appointed as a research fellow for traumatic brain injury under the mentorship of Dr. Donald Becker, who greatly influenced him to take up neurosurgery residency. He then completed his general surgery and neurosurgery residency between 1977 and 1982 at the Medical College of Virginia, Richmond. And that's the building of the hospital you're seeing there. So this is Dr. Raj Narayan, photograph on the left as a resident. He was influenced on various aspects of neurosurgery training and mentorship by these individuals mentioned here. Dr. Harold Young, who according to his own words, was in the trenches with us in ensuring good patient care. Dr. Pawlik with a scientific mindset, and Dr. Becker, who was full of life and was an inspirational leader, according to Dr. Narayan. And this is in the later years when he visited his alma mater for a neurosurgery residence research day. His photograph with Dr. John Ward, Dr. Harold Young, and Dr. Pawlik. After his residency, he held various faculty positions, the first being at the Baylor College of Medicine, Houston, Texas, for a brief period. And then he went on to become a chair of 3 different institutions, which he built up to great strengths before leaving them. He became a chair of the Temple University in Philadelphia when he was 42 years old, which is quite young and quite unheard of for a person outside the United States on those days. During these stints, he has mentored and trained more than 100 neurosurgery residents, some of whom have established excellent careers worldwide. He also established the neurosurgery program at the St. Francis Hospital, New York, just a few years ago. His focus of interest has been tumors, traumatic brain injury, spinal disorders, and hyperhidrosis. And these are the various institutions which he chaired over the last 40 years. He has received multiple large research grants on traumatic brain injury, has 140 publications and 60 book chapters. We have all benefited from reading the textbook on neurotrauma that he co-edited and presented as a gift to our department library. He's been honored with several awards and has been the Chandy Orator at the annual Neurological Society of India meeting in 2003. He has 2 patents on sensors in monitoring patients with head injury. Dr. Narayan has always been a well-wisher of our institution and department, and he's presently the chairman of the Vellore Foundation, working tirelessly to obtain funding for our upcoming pediatric block, as well as for research activities in CMC. He's also been involved in developing the Indian head injury guidelines. He's married to Dr. Tina, who is a pediatric neurologist and also from the University of Virginia. And they have 3 grown-up children and 6 grandchildren. And here's an occasion of them celebrating Christmas as a family. Due to issues with travel logistics, Dr. Raj Narayan had to change his plans to being physically present today. He's kindly, however, decided to stay up the whole night to attend this meeting and grace us with his talk on improving outcomes for TBI. Presenting to you, ladies and gentlemen, Dr. Raj K. Narayan, CMC MBBS alumnus and neurosurgical leader. Thank you.
Thank you so much. It's such a pleasure for me to be there, friends. I'm really deeply, deeply honored to have been asked to give this oration that recognizes the first neurosurgeon in India and also the first person who was my principal when I joined as a medical student in 1969. There is no bigger honor for me than to be honored by one's own family, and so I really, really appreciate it. There's so many people that I would like to thank, that I could spend the whole time that I've been allotted in thanking people. I would especially like to, of course, mention Dr. Murthy for the invitation, for all the wonderful talks that we've heard today, for Dr. Matthew Joseph and Geeta Chalko, especially Dr. Joseph, who I've known and worked with for many, many years. Dr. Matthew Chandy, who I was taught by briefly before he left CMC. Dr. Raj K, who's been a long-term friend and advisor. Dr. Chandran Nyanamuthu, who was a year senior to me, and our paths have crossed over the years several times. Dr. Dhaval Shukla, of course, from NIMHANS. Deepak Gupta, he's sort of a wonderful expert on TBI, again, interest that I've shared. I'd also like to thank all the postgraduate students and the nursing staff and an institution which has essentially been what gave me my whole career. Let me start at the beginning. I'm going to go quickly. I'm going to zip through a lot of slides, so please forgive me, but I'd like to tell you my story and see if this is something that is of interest to you. So here are my parents who were married in 1949 at the young ages of 25 and 21 in Secunderabad. They had two sons, me and my younger brother Kailash, who's 5 years younger to me and who is also a neurosurgeon. My dad was born in Bangalore. He joined the Indian Army after finishing his law degree in Hyderabad. He was involved in all of the wars that India has fought with Pakistan. He became a paratrooper, trained a large force, was military attaché for India in Cairo for 4 years during the 67 war, spoke 8 languages, and continued to work all the way till he died at the age of 82. I was born in 52 in Secunderabad. I grew up in various army towns. And then my parents decided that they were moving me around too much. And I was admitted to the Hyderabad Public School in Hyderabad in 1962. Here's the beautiful school. At the time, it was a very good school, but I didn't realize that in years later, it would produce a whole bunch of CEOs of major multinational companies like Satya Nadella, Shantanu Narayan, Ajay Banga, Prem Watsa, who is the Warren Buffett of Canada and who has donated the bulk of the money that is being used to build the Children's Hospital on the Ranipet campus, and others. There are many, many notable alumni. Another connection is that my principal was Kurvila Jacob, who is father of Dr. Sulochana Abraham of Chad fame. And my second principal, actually he was vice principal at the time and then became principal, was Mr. M.C. Watsa, who is the father of Prem Watsa, who later on connected again as the donor to CMC. Now, when I was maybe 13 or 14 years old, I read this book called Death Be Not Proud by John Gunther, who was a travel writer, whose 17-year-old son, Johnny, many of you may have read this book, developed a malignant brain tumor. It's a very moving book. And I'm sorry to say that although we've learned a lot about malignant brain tumors since then, the prognosis is not a whole lot better now than it was in 1947. But I decided this is what I wanted to do. I wanted to become a brain surgeon. And at the time, Vellore was the first neurosurgical center in the country. And I decided I needed to go to CMC. By some luck, I managed to get in. And you all know the story of Dr. Ida Scudder, who lived for 90 years, never married. Her whole life was devoted to the growth of this most special institution. Men were admitted into CMC only in 1947, and Dr. Jacob Chandy got there just a couple of years later. You've heard all about Dr. Chandy, so I won't spend too much time on this, but we know that he lived to a ripe old age. I'll just make one point that was perhaps not touched upon, and that is that he retired in 1970 at the age of 60, and he died in 2007 at the age or 37 years later. And there is sort of a recurring theme with this, where it looks like if you work hard in neurosurgery, you're likely to live a long time. This is a rather biased sample, but it's an interesting thought. So this paper, which has already been alluded to, which Dr. Jacob Abraham, Mathai, Raj K, and I wrote about Dr. Jacob Chandy, but it gives a lot of the history of CMC as well. So here was the Bagayam campus and men's hostel back in the day. And as has been mentioned, the two twin towers, because Dr. Chandy had retired by the time I came into my clinical years, were Dr. K.V. Mathai and Dr. Jacob Abraham. So Dr. K.V. Mathai also lived for 91 years, and his description by Dr. Jacob Abraham is quite accurate. He was as constant as the northern star, led by example. His punctuality, discipline, careful surgery, neckties, teaching, and patient care were the gold standard against which all others would be compared. I think that kind of sums it up with Dr. Mathai. And then Dr. Jacob Abraham and his wife, Amu. I was General Secretary of the Students Association, and we started this program where faculty would adopt students. And I kind of adopted myself to Dr. Jacob Abraham, and he then became a lifelong mentor with his most characteristic pyramid-styled mustache, which would twitch a little bit when he was trying to smile or to make a joke. It was very, very typical of him. He told me at one point, if you can make just a small impact on your field, you would have accomplished something. And, somehow that stuck in my mind. And I've been trying for the last 50 years to try and accomplish something. And here we are. What got me started with research was Bimal Bachawat, who was a neurochemist and glycobiologist. And Dr. Chandy had this foresight to start a department not just of neurosurgery, but of neurological sciences. Dr. Bachawat, with his characteristic pipe, would sit up in the Williams building and It was such a pleasure to work with him, and he got me started looking at the immunosuppressive effects of this plant lectin called concanavalin A. And that resulted in a paper because I was able to get monkeys and use them. The gypsies would catch the monkeys for me for 10 rupees. And I'll never be able to do that again, but it was a phenomenal way to get started on a research career. This paper was published in Transplantation in 1976. CMC also introduced me to this lovely young lady, Christine Matthias, who was 4 years junior to me, and we subsequently, many years later, got married. But in 76, I moved to the US with the proverbial $8 in my pocket. A big risk because I was leaving the certainty of great training at CMC for an unknown future. So I got to Richmond. I managed to get a job with Dr. Becker. That's a whole story that I can share with you some other time. But I worked for 6 months as a fellow on the newly achieved traumatic brain injury program. And Dr. Becker was a very charismatic guy. In this picture, he looks a little older, but he was 36 or 38 at the time. He looked like he was 20, and he was just full of life, a little bit crazy, but very inspirational. Harold Young was the vice chair, and he is still alive and is the chair emeritus. And he made me very welcome. He and his wife invited me over to their home for Thanksgiving, and it was a wonderful experience. Douglas Miller was from Scotland. He was a Scottish professor. From him, I learned how to think, how to write, how to be a good surgeon, but not be a jerk. He was just a wonderful, wonderful guy. Unfortunately, he returned to Edinburgh later on after I finished my residency as the professor there, but died prematurely at the age of 58. John Pavlichok was a young assistant professor. He went on to become one of the most celebrated researchers in the field of traumatic brain injury, was the founding editor of the Journal of Neurotrauma, and he remains a friend to this day. He is retired now, but he can be credited with doing pioneering work on diffuse axonal injury, the blood-brain barrier, neuroprotection, and all sorts of important subjects. So here's a picture getting started with my residency, and then finishing it 6 years later. I moved up the road to Bethesda, Maryland, because I wanted to be a brain tumor doctor, if you will remember. And I wanted to study brain tumor biochemistry. And the NIH seemed to be the perfect place to do it. There I was able to work for 3 years doing part clinical and part lab research and getting quite a bit of experience in doing a whole bunch of lab tests looking at brain tumor biochemistry. At that point, I got recruited by this gentleman, Dr. Robert Grossman, who had taken on the chair at Baylor College of Medicine in Houston. And he recruited me to Houston, and I worked with him for the next 10 years at the Texas Medical Center, which, if some of you have been there, can testify, is a phenomenal complex, this whole, all these buildings in the foreground are all hospitals or medical institutions. By comparison, this small clump of buildings in the back here is downtown Houston. So I had the pleasure of working here for 10 years. We got a huge NIH grant in head injury because I was in charge of Bentob and we had a large number of head injury patients. And it became, along with Claudia Robertson and later on Shankar Gopinath and others, it became the most successful head injury program. My brain tumor research continued in the lab for a few years, but then I didn't have time for both. And every time I said, what should I speak on when I was invited, people said head injury. And so brain tumors did not survive. At that point, about 10 years into this, I was offered the chair at Temple University in Philadelphia. I really wanted to run my own program, and I decided to take it. This was one of the original 20 programs when the Neurosurgery Board was founded. But it is in a poor part of Philadelphia, and when I got there, there was only one other faculty member and three residents. So from there, I had to rebuild the program and get it up to speed. And 7 years into that, the program had become totally self-sufficient and was doing well. And at that point, I was offered the chair at the University of Cincinnati, which is a very big program in the neurosurgical world because of the relationship with the Mayfield Clinic. It became hard for me to turn that offer down, and we moved to Cincinnati. I stayed there for 7 years also and learned all about the relationship between town and gown, between private practice, Mayfield on one side, and the dean and the medical school on the other side, with the chairman in between getting pulled in opposite directions. Nevertheless, we made the program grow more and more academically, and the number of residents going into academic positions increased fourfold during the course of my 7 years there. 3 years after I left, the relationship between those two entities broke down, unfortunately, and that's a whole other story that we can go into some other time. So this is the University of Cincinnati College of Medicine. And so from there, I went to New York in what at that time was called North Shore Long Island Jewish Health System, which in collaboration with Hofstra University started the Zucker School of Medicine and then the name changed to the Northwell Health System. I went there as chair of neurosurgery and director of the Institute of Neurology and Neurosurgery and senior vice president of the neurosurgery service line. We went from 8 hospitals to 23 hospitals, and more recently, they've grown even further to 28 hospitals in the system. Those of you who are not familiar with New York geography, this little sliver here is Manhattan, and this whole piece of land is Long Island. So you can see Long Island is larger than a couple of states, and it has a population of about 6 million. The North Shore LIJ Health System, or Northwell, started there, but then it has expanded into Manhattan and into Connecticut. So we went from, when I got there, we had 8 neurosurgeons. When I finished my tenure there, we had increased that to 41, and we went from 1 neurocritical care doctor to 10. And proportionally, the volume and the clinical material went up. This was the mothership, North Shore University Hospital in Manhasset. It has a 22-bed neurosurgical ICU with full-time neurointensive coverage, and recently completed new ORs and an ICU pavilion. Long Island Jewish Medical Center is about 2 miles south of this. And then there is Cohen Children's, which is attached to LIJ, which is the pediatric hospital. And then in the city, meaning in Manhattan, we have Lenox Hill Hospital, which there was also a television show based out of Lenox Hill that some of you may have seen. The residency program, as I mentioned, switched from originally a DO program to an MD program, and then it has also increased in size to 3 residents per year for a 7-year program. And it is based out of the 4 hospitals that I mentioned. It has a Feinstein Institute, which is right next to North Shore University Hospital, which is the research campus for the medical school, and the residents can pursue a PhD at this facility, or at Cold Spring Harbor, which many of you must have heard of, which is a very well-known research institute, which has since become affiliated with Northwell. So some of the residents have had the opportunity to do their research time at Cold Spring Harbor. So the department grew enormously, and then I became chair emeritus in 2022, actually in 2021, I'm sorry. And then I was asked by St. Francis, which is another hospital in the region, to help them get their program going. So I did that for 2 years till I stopped operating about 1.5 years ago. So that's the story of my clinical path. Research-wise, I got hooked, as I mentioned, with studying the injured brain during my time in Richmond. So this was the mystery box. There was very little we could do to look into it. CAT scans had just come out, and here we were dealing with a common problem, a huge problem with very limited tools. So over the next 50 years, I've broken down the research efforts into 6 phases, which are listed here. The first was aggressive treatment. And I say this as a phase because back in the day, when we first started, the general attitude was there's nothing that you can do about traumatic brain injury. Leave the patients in the corner. If they survive, we'll send them to rehab, and that's the end of it. If they had a hematoma, then once CAT scans came out, they would be taken for surgery and then put in the corner. This was before neurocritical care was even a specialty that was developed or recognized. So we went on from there to study cerebral pathophysiology, and I'll go through these very quickly. So let's start with the aggressive treatment. So this was while I was in Richmond with Don Becker, Douglas Miller, and others. And we started treating all patients who were comatose with intubation, monitoring all of their labs, doing CAT scans every day, doing ICP monitoring, and later on doing cerebral blood flow studies and so on. And the one basic question was, can the outcome from TBI be improved with our efforts, or is it established from the moment of impact, in which case nothing that we do is of much value? So Becker had this concept that head injury is a process and not just an event. And so what happens initially is complicated and compounded by a whole bunch of bad things that happen subsequently. So our job then would be to provide the injured neurons with an optimal milieu for recovery, and this will allow them to survive and lead to improved outcomes. The first paper that I published actually remains my most quoted paper, even now, is this paper that we did with a prospectively collected database of 207 patients with severe head injury. And we discovered that patients with a normal CAT scan, even though they were comatose, they had a lower risk of having ICP elevation, a 13% risk. Whereas if you had an abnormal CAT scan, that risk increased to 60%. Unless you had two of these adverse features, that is, if the patient was over 40 years of age, was hypotensive, or had motor posturing, in which case, even if their CAT scan was normal, they had a higher risk of raised intracranial pressure. Over that period of time, we did early intubation, rapid transport to our designated center, prompt resuscitation, early CAT scan, prompt surgery when needed, proper monitoring, and attention to detail in a neuro ICU. In terms of ICP monitoring technology, we tried different things, but the old tube, the ventriculostomy, which was described by Gulami and Jani in 1951, was the best way to do it, and to this day remains the best way to monitor ICP and to be able to drain CSF as needed. We published a whole bunch of papers relating to outcome predictions, multimodality, excuse me, evoked potential, monitoring, prostaglandins, etc. And I won't go into any detail on all of these in the interest of time. But then, as I mentioned, I moved to NIH and then on to Houston. And there I had the privilege and pleasure of working with Claudia Robertson, who is a neurointensivist, and Dr. Grossman, and we collected a team of people. As has been mentioned earlier, nothing is done by one person. And if I had any advice to give to the young ones in the audience, I would say, try to work with smart people, because that has been what has made my whole career, is being able to work with people who are much, much smarter than I am. And by being able to bring these people together, we've been able to do a lot of good things. The people mentioned on this slide, some of them, well, all of them have contributed hugely to the field of traumatic brain injury. I put this slide up only because if there's one thing which is important to know, is you need to keep the blood pressure up in patients who may have a mass lesion. And this study by Randy Chestnut from way back shows that if they have neither hypotension nor hypoxia, their mortality is 27%. With hypoxia, the mortality goes up a little bit to 37%, 33%, sorry. With hypotension, it jumps up to double that. And if you have both hypotension and hypoxia, your goose is kind of cooked. So everything you do, try to keep the blood pressure at a good level. And Claudia Robertson showed this with her blood flow studies, where she showed that patients with elevated blood flow, corrected for age, the probability of a good outcome is best in these patients. It is worst in patients with a reduced cerebral blood flow. So based on this, a study was proposed whereby she tried to elevate the cerebral perfusion pressure with vasopressors. And what that showed was this is jugular desaturation in patients who were treated with ICP alone and those in whom the blood pressure was jacked up to improve cerebral perfusion. And what she showed was that there was a 20% drop in the incidence of hypoxic episodes in those in whom the blood pressure was raised. However, she also found that if you try to raise it too much, patients get ARDS and other bad things in the lungs. And so that's how we came up with the current recommendation, which is to keep the CPP at around 60 to 70, not much below that or above that. This study was done by Zev Feldman, who was our fellow at the time and has subsequently gone on to become president of the Israeli Neurosurgical Society. And what he showed was that nursing patients with the head 30 degrees up was actually better than if they were left in a flat position. There were several studies with cerebral metabolism, which are listed here. Again, in the interest of time, I'm not going to go over them. But the long and the short of it was that the optimal management of severe head injury was keeping the systolic blood pressure over 90, monitoring all patients with a GCS of 8 or less, keeping the CPP between 60 and 70, minding the temperature and not allowing the patient to become febrile, keeping the serum sodium over 140 if possible, using hypertonic saline if need be, keeping the brain tissue oxygen over 15 using a Lycox monitor, and I'll come to that in a minute, keeping blood glucose between 80 and 140, using seizure prophylaxis for the first week, CT scanning early and repeating as needed, and doing a decompressive craniectomy early if the ICP is not otherwise manageable. All this is a lot of work, but if you do it, the likelihood of a good or a better outcome is substantially improved. At the present time, there is a study going on that you may be aware of called the BOOST 3. It is to treat patients with a GCS of 8 or less. It is an NIH-funded multi-center prospective randomized trial that compares treatment based on ICP alone versus that based on brain oxygen data. The patients are still being accrued, and hopefully in the next year or so, we will have some results. We started working on developing technology to improve methods of monitoring the brain. This was started, as I mentioned, back in Richmond, but then continued in Houston and continued when I went to Cincinnati. I was able to recruit a young lady called Chunyan Lee, who had just finished her PhD in engineering at the University of Cincinnati. She started doing work on developing a monitor. I mentioned the Lycox, and you all are familiar with this. This was to monitor brain oxygen. And there are many other devices that I won't belabor. But we started looking at ways to monitor in a more reliable and comprehensive way. The jugular saturation monitoring was one of those techniques, which never really took off because it had its issues. Shankar Gopinath then was a fellow, and he did an evaluation of what subsequently became the Integra Codman microsensor. And we also did the early studies with the near-infrared scanner that has been spoken about already. So Dr. Lee started to work on the microsensor, which is shown in this figure. It looks like a very thin catheter. And the idea was, could we measure multiple things on a single monitor? And this is what the laboratory model looks like. And this is the part that goes into the rat's brain. And it has been shown in rats that you could monitor EEG DC potential, which is what you need to be able to monitor for spreading depolarization. Brain oxygen levels, glucose, lactate, temperature, and cerebral blood flow. So for example, here the cerebral blood flow drops, you start getting a drop in EEG potentials, you start getting spreading depolarization, the oxygen level drops, glucose level starts to trend down, lactate increases, and the temperature goes up after a while. And later on, the ICP starts to go up. So this is what we were shooting for. Unfortunately, although this thing works beautifully in the lab, the companies that manufacture these things could not be convinced to take this on. Maybe in future years, one of you young ones can take this and make it commercially viable because this is what we need. This will tell us about what's happening in the brain before bad things happen, rather than simply trying to fix it once the badness has occurred. We've published a whole bunch of papers on the smart sensor, as are listed over here. And so much for that. Another person that I was able to recruit in Cincinnati was Jed Hartings, who was a PhD, young guy at the time. He had an interest in this thing called cortical spreading depolarization, which had been described by a Brazilian physiologist many years ago. But he started looking at it in an animal model. So this is a phenomenon that causes a spread, as you can see in this figure, from the point of injury, you get a spread of depolarization at 2 to 5 millimeters per minute. It doesn't seem to be limited by arterial territories, and it spreads in the gray matter by contiguity. Dr. Hartings stayed on in Cincinnati after I moved to New York and continued this research, and he's become the high holy priest of cortical spreading depolarization and has published a lot of very good papers on this subject. So when we started doing it, we were putting cortical strips after we did a craniotomy for a subdural and closing it, and the strip could be removed later on after about 5 days. And here you see that what you get by monitoring it that way is are these cortical spreading depolarizations, which, by the way, do not show up on a normal EEG, but requires a special type of equipment to be able to pick it up. And it has since been reported that cortical spreading depolarization occurs in all sorts of acute neurological events, including traumatic brain injury, hematomas, aneurysmal subarachnoid hemorrhage, and even malignant ischemic stroke. So you've all seen patients who are looking quite good, and then 2 minutes later they're looking like dead. This is probably chronic cortical spreading depolarization at work. And it has now been associated with poorer outcomes in all of these different conditions. And this paper by Jed Hartings in Lancet Neurology is a good summary of this subject. Now, we also started to get involved in a bunch of pharmacological trials in TBI. And the people listed on this slide are various people who have been involved with this. And of course, there are many, many more that are not on the slide. The general idea was that after a head injury, you get an initial 6-hour phase of excitotoxicity with NMDA activation when the calcium ions get into the brain cells. And if you could stop that, then perhaps you could make things better. After that, you get an inflammatory process. And so if you can do something to prevent that, maybe you can make things better. All of this leads on to neuronal death. Some of the pharmacological trials that had been reported are listed on this slide. A lot of interesting studies, some of which showed a signal, but were phase 2. The phase 3 studies have not, to date, shown a positive outcome. A couple of studies I'll mention. This study I was involved in looking at the progression of traumatic intracerebral hematomas, looking at it because patients who sometimes come in with a normal-looking CAT scan then go on to develop very nasty intracerebral hematomas. We did this study with recombinant factor 7A with a dose escalation design and showed that patients that were given factor 7A did have a slower growth of the hematoma size. Unfortunately, Novo Nordisk, that made factor 7A, decided not to put extra money into doing a phase 3 trial in order to really nail this down. But this is something that you should keep in mind as an option in patients that have multiple intracerebral contusions that are at risk of getting worse. And this is a study that needs to get done because I think that there is definitely a positive signal there. The Synapse study was one with progesterone. At this time, there had been a lot of very strong data coming out of the lab indicating that progesterone seemed to have a very beneficial effect in the laboratory models of severe TBI. The Synapse trial, which we did, recruited 1,100 patients in 21 countries and was completed in 2014. Unfortunately, although this was published in the New England Journal, the results did not show a beneficial effect in these patients. Another study done by the NET group at the same time, called the PROTECT trial, slightly different dosage and timing, that also turned out to be negative. So I think that was the death knell of progesterone, at least for the time being. There are other drugs like high-dose barbiturates, which are not used as much now because of decompressive craniectomies, and propofol, which is a useful agent when you want to keep your patient sedated. This paper, Clinical Trials in Head Injury, goes over all the various reasons why trials have not worked so far. And this is a whole talk in and of itself that we can do at another time. But there are many reasons why these drugs have not worked, even though they've done great in the lab. And one of the things is that you have to have patients treated in a very standardized way in order to pick up the signal. The other is that our outcome measures have been less than optimal in defining, you need a very large number of patients to pick up the signals. One of my colleagues at Cincinnati, Dr. Keith Crutcher, looked at the question of what are the genetic factors involved in outcome. And he studied the ApoE4 allele and found that there was a significant relationship between outcomes in TBI and having a double ApoE4 allele. So that's another thing to complicate matters. So while we were doing all of this, it also occurred to me that it wasn't very helpful if patients in a few centers around the country were getting all this fancy care where 99% of the patients out there were not. And so we said we know enough already that we should at least standardize what we already know, and thereby started the whole push to develop guidelines. And we were the first surgical discipline to develop a guideline for anything. So we got together with the support of the Brain Trauma Foundation, and we started to work on guidelines back in 1995 and published the first set of guidelines. It is now the people involved with this, myself on the left, Tony Marmaru, may he rest in peace, was a wonderful, wonderful PhD who did a lot of clinical research and was the executive director of the American Brain Injury Consortium for many years. Jam Gajar, neurosurgeon and president of the Brain Trauma Foundation. So These guidelines were developed. They're now, the fourth edition has been published already. We are now working on the fifth edition. Between the first and the fifth edition, I got busy running these departments and so on. So I didn't really stay engaged with the guidelines development. This is the fourth edition, which was in 2016. And as I mentioned, the fifth edition is now in preparation. And I have come a full circle and gone back into working with this group in developing this. Now, do these things make a difference? I'll give you two case studies. This was, both were by Jam Gajar, and this was done in Eastern Europe with a grant funded by the Soros Foundation when Eastern Europe was just becoming part of the West. And the healthcare there was not very good. And so this grant paid for teaching courses for neurosurgeons to be taught the basics of neurocritical care, ICP monitoring, respirator management, and so on. The compliance with the guidelines over a 3-year period, you can see, had a nice upward curve. And what this showed was that before the guidelines, the mortality in this group was about 50%. And after the guidelines were initiated, the mortality dropped by about half. You're never going to get a randomized study of this issue, but historical data such as this is about as good as it gets. Again, the good recovery at 6 months, without guidelines, 18%, with guidelines, up to 39%. Now, a similar project was initiated in New York State over an 8-year period with 20 level 1 trauma centers. And again, the compliance with ICP monitoring went up during this time. The case fatality showed a nice downward curve from 26% to 13%. So it's about half. The CDC independently reported that patients are twice as likely to survive if the guidelines are followed, and the proportion of patients with good outcomes rose from 35% to 66%. The proportion of patients with poor outcomes fell from 34 to 19, with a potential saving of many billions of dollars. But what really made the guidelines really catch on were their adoption by the American College of Surgeons, which made it part of their review when they reviewed hospitals for level 1, level 2 trauma center status. Because of their insistence, the compliance with the guidelines went up substantially. And here's a paper which has been described, a management algorithm for making it simpler to use the guidelines. And this has broken up the treatment into tier 1, tier 2, tier 3 treatments. So you can go up from 1 to 2 to 3. It helps to quantify how much treatment is needed to control intracranial pressure. And if you're unable to control intracranial pressure with these measures, then you go into a decompressive craniectomy option. Now, with all of this, has there been any improvement? If you look at it again historically, When I started my residency, the mortality from severe TBI was about 51%. By 1998, papers reporting the use of intensive care and all the things we've talked about, mortality appeared to have dropped to 31% without a substantial increase in vegetative survivors. So they were going from dead to either good outcomes or moderately disabled outcomes. Current reports are all talking about 20% mortality. It's a little hard to say whether that is all due to things that we do or whether it's due to a combination of factors. But needless to say, it appears that with proper treatment, you can make a very huge difference to mortality. I borrowed this slide from Dr. Franco Cervide because it made the point that I want to make, which is the picture on the left shows where all the papers on TBI are coming from, Europe and the US, and some from China and some from India. And when you look at the incidence of TBI, you see that India is like the hot spot. And the incidence of road traffic accidents in the US has dropped substantially. So more of the head injuries in developed countries is now due to falls, often compounded by anticoagulation. So back in 2014, we decided to get the Indian trauma guidelines process going. And I raised some money and held a conference in Delhi. And several of the people who are at this symposium were involved with this. And it helped to get the first set of India-centric guidelines going and started to get buy-in from all the concerned entities. And this was subsequently taken over by the Indian Neurotrauma Society. And I'm delighted to see that it has been published and it is being promulgated and used. So this was when we started. We had Amitabh Bachchan and the Maharaja of Jodhpur helping to launch it. We do anything to get this thing off the ground, and happy to say that it did get off the ground. More recently, there's been the growth, and just a couple of weeks ago, the inauguration of the International Society for Global Neurosurgery, which its mission is to help spread the availability of neurosurgery, neurocritical care, trauma surgery, anesthesia, etc., in parts of the world where there's simply not enough. So the group that has got it together on this is a good group. I would encourage all of you to become involved and do your little bit to make things better in parts of our country, meaning India, where the quality of care may not be the same as at CMC or NIMHANS or All India Institute. So some of the conclusions: we now have a much better understanding of what optimal care for severe TBI is than we did 50 years ago. Better care does result in better outcomes. Trauma surgery and neurocritical care have now, in the last 20 years, grown dramatically as new disciplines. We have helped to change the standards of care for TBI across the US by the different things that we have talked about. It's important to pay attention to the details. Better monitoring technology would be helpful, and I urge some of you to pursue what I talked about with the multimodality monitor. Proving the effectiveness of specific drugs or treatments is difficult and expensive. However, it will eventually happen. Although no single drug, in my opinion, will be as effective as good clinical care of the type that we've been talking about. It will be difficult to statistically demonstrate the efficacy of a drug unless we standardize management across all the centers that are involved in a study. And we are working on improving the standards of care around the world. Now, a little bit about non-pharmacological treatments. And the next few slides are primarily the work of my associate, Dr. Chunyan Lee, who I was fortunate to have been able to recruit from Cincinnati to join me in New York. And she still continues to work at the Feinstein, and several of our residents have worked with her in the lab. And I'll just give you the high points of some of this work because I think it's interesting and novel. So the emphasis has been looking at trigeminal nerve stimulation as a treatment for traumatic brain injury. And it turns out that it may be helpful for not GBI, but also subarachnoid hemorrhage. So here goes. These are the many different ways that you can do neuromodulatory approaches. For any of you interested, the modulation technology at the neural interface in 2021. Many different uses have been published, are shown in this on this slide. And just to refresh your memory, the trigeminal nerve through the brainstem connects to the autonomic nervous system and also connects to the cerebral blood vessels. And it looks like, based on the work that Dr. Lee has done, that CGRP is probably the main substance involved in this vasodilatory effect of trigeminal nerve stimulation on the cerebral vasculature. And it appears to do this in a dose-dependent manner. It increases cerebral blood flow. And it does not seem to be only because the blood pressure goes up, because when you spinalize the animals, the blood pressure doesn't go up, but the cerebral blood flow still goes up. And as I mentioned, CGRP appears to be related to this vasodilatation. So TNS induces changes in cerebral blood flow due to vasodilatation, and these can be affected by the stimulation parameters. In pericontusional areas complicated by hemorrhagic shock, she has shown that TNS preserves cell viability in the pericontusional area and also reduces hypoxic brain injury, as shown in some of these studies. So the conclusion of those studies was that it modulates cerebrovascular tone and increases cerebral perfusion. And she's also looked at low frequency CBF oscillations that seem to improve microcirculation and oxygenation. And these animals have better survival and neurological recovery. There was a set of studies done by a company called Helios, where they looked at using stimulation of the tongue as a way of doing trigeminal nerve stimulation. and using it in patients with chronic balance disorders following TBI, and showing that there appeared to be a substantial improvement in patients who had received TNS, trigeminal nerve stimulation, in addition to physical therapy. Unfortunately, the company got kind of waylaid by people on Wall Street, and the FDA did not approve their application on the first go around, and so they got killed on Wall Street. Their stock dropped, and they then did not have the money to do a full phase 3 trial of this. But again, this is another thing which requires the next generation to take it up and study it further, because there does appear to be a signal, and I think it should not wait till chronic phases of TBI, but should be done even in the acute phases of TBI. Another study by one of our residents looking at TNS in cerebral micro and macro circulation. And I'll just cut to the chase. It appears to protect against cerebral vasospasm, and it also reduces cerebral microthrombi. And it is a vasodilator. TNS is a vasodilator, you know that already, and it decreases inflammation as well. I'll skip this. So it reverses vasospasm, reduces inflammation, enhances cerebral circulation, reduces delayed ischemia, and improves neurological recovery in an animal model. And we believe it may represent a new tool in the management of both TBI and subarachnoid hemorrhage. I believe that a clinical study is being initiated now in a different center to look at this clinically. And that is another exciting area. Also, it can be used for hemorrhagic shock. I won't belabor this, but instead of the usual way of doing resuscitation, one might think of trigeminal nerve stimulation as a resuscitation device. It does seem to improve survival rate from hemorrhagic shock, again, in an animal model. So it's effective for treating hemorrhagic shock, etc., etc. We've gone through this, but much more work needs to be done to take it to the next step. That is to get these things proven at a clinical level and adopted clinically. Now, in the last part of my talk, I just want to mention that I have now come a full circle, and I've been working with the Vellore CMC Foundation, which was the board which ran CMC till 1947, at which time it transferred the governance, as Dr. Chandy mentioned, to India. Now it does mostly fundraising and friend raising, and I've served on the board for 9 years, and then by rules I have to get off for 1 year, and then I came back and then got elected as chair of the board last year. Now this foundation, we are very excited about it because the role of the foundation is to raise money and to help guide CMC in whatever way we can, from a distance. And we raise money from alumni, from the Scudder family, from churches, and from other people who have nothing to do with Vellore, but hear the story and become excited about it and become part of the family. So we've been very involved in trying to get a better understanding of what is going on at CMC so that we can help you do better. Just look at this slide, which John Reel, the CEO of the foundation, provided to me. The charitable contributions have gone up, as you can see in the left graph, very substantially. And on the middle graph, you see the amount of programmatic support sent to CMC has been 34 million in the last 7 years. The administrative overhead has been cut down to 3%, which is much, much lower than most foundations, where they can spend up to 20% on overheads. Now, this graph also includes the money that was raised for the Children's Hospital, which, now it sets such a high bar that it makes us nervous as to how we're going to keep doing what we did. So you can see on these graphs, the money has gone for patient services, education and research, and capital improvements. The scale on the y-axis is different, but here again, this huge increase here is because of the Children's Hospital funding. In addition to fundraising, we also help put you in touch with people that you may want to connect with at universities in the US. And some of the relationships that have been formed are shown on this slide. But there are alumni in different parts of the US. And so this would be another avenue for you to use if you want to connect with people in the US for research or clinical collaborations. While doing all of this, I've somehow managed, with the help of my lovely wife, Tina, to have 3 children and 6 grandchildren, and they clean up nicely for the right occasion, and thankfully they're all doing well and are happy. So to come to the beginning, I keep thinking of this Dr. Jacob Abraham statement. And, if you can make just a little impact on your field, you would have accomplished something. And I was hoping to come to Madras and meet Dr. Abraham before coming to Vellore for this talk. And he was very inconsiderate and decided to leave us 2 weeks ago, which now leaves me in a position of never having that question answered. I was going to ask him if he thought that I'd made enough of an impact, but now I just have to keep working to try to make it. So with that, I will stop, and thank you very much for your attention and for letting me go on for a little longer than I should.